Welcome everybody to the third and final session in our 2003 Maternal Health Learning Series. I'm Jen Anderson, Clinical Quality Improvement Director for CHAMPS, your Region 8 Primary Care Association. CHAMPS, or the Community Health Association in Mountain Plains State, supports the needs of health centers in Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. So today I'm really excited. We're going to hear from Dr. Elizabeth Cherot of the March of Dimes on their 85-year history of collaboration with partners, communities, and patients. We're going to be talking about March of Dimes research on maternity care deserts and kind of discussing the role that health centers can play in addressing that crisis. And I know us focusing on access is kind of a newer focus area, so I'm really hoping we can all just kind of get some really great level setting, kind of have some ideas on how we're really going to be going forward with this over the next several years. As you all know, maternal health is a federal priority area, and so we are so thankful to Captain Alicia Aker for working with us to create this series in partnership with the Region 8 Office of Intergovernmental and External Affairs. While we're all getting started, I want to encourage you all to put your video on if you can. If you're having lunch, of course, please, take care of yourself on this break. But we'd love to get a good idea of who is in the room with us today. If you are having trouble with any technical difficulties, please do reach out to Haley at Champs Tech Help in the chat, and she can get you all settled. So excellent. Our speaker today is Dr. Elizabeth Cherot, MD, MBA. Dr. Cherot is President and Chief Executive Officer at the March of Dimes. She joined the March of Dimes in January 2023 as a Senior Vice President and Chief Medical and Health Officer before moving into her CEO position in July of this year. You can read all of Dr. Cherot's impressive bio in our handouts for today's event, and Haley has included that in the chat for all of you. You can see the bio and all of the handouts for this particular presentation, which of course we will be sending in a follow-up email after the event today, if you don't have access to those. And with that, I would love to turn it over to Dr. Cherot. Please feel free to share your screen.
I'm working on that. So let's see. And if you can confirm with me, Jen,
I absolutely will.
See it. If you can see it, then I'm hoping everybody else can. I have it in a PDF form rather than slides. It was too big to share. And so, but as usual, getting through the digital and the IT hiccups, usually the rest goes smoothly. So thanks for having me. I'm really excited to be here. Yes, I joined the March of Dimes in January. My prior role was in a large OBGYN group. I'm an OBGYN by training, almost 30 years of delivering babies. I really on the East Coast, but I do have a stint in Alabama, and I have a stint in Montana. I actually in medical school worked for the Indian Health Service out of Billings. So, and not something that's way back. But Montana has always been one of those where I started in Billings and actually went all the way up to Blackfeet and all the way down into Wind River, Wyoming. So, got to do a research project there when I was in medical school and really enjoyed it. So, once again, thanks for having me. And my role is very different now. I always think of, my prior role as chief medical officer was more about herding cats with OBGYNs in a very large group in Kentucky, Ohio, Indiana, and New Jersey and Pennsylvania. When I stepped up into the March of Dimes in January of this year, it was really to be the chief medical officer. And then after a few months on the job, realized that the opening for CEO, I put my hat in the ring with the board, mostly to have a bigger impact broadly, but also knowing that I was going to be the first physician. It's sort of interesting that out of the 6 presidents of an 85-year-old non-for-profit, I'm the first physician. So, and enjoying the role. And really find that stewarding this in the right direction, and both from a financial standpoint, but also really on the mission side is really a nice sort of intersection for me personally. So this is right. Our statement, our vision is that we lead the fight, or really our mission for the health of all moms and babies. So our vision is that all moms and babies should have a healthy start, regardless of where they start from. Wealth, race, gender, or geography should not change that. And we know that health disparities really are affecting our moms and babies. And I'll get into some of the data today. So this comes directly out of our report card in our maternity care desert report, which I am going to highlight mostly because I'm super proud of it, but also you can access it. It is for free, which we probably need to change, but it is still for free on our website. And I always encourage everyone to go in and look at their county, because, we know that the US is the most dangerous place to deliver a baby, which is unbelievable to think about for industrialized nations, that we are the worst. We know that access to care is a big problem as you look at the swath of red across the country. When 2 women die, every day, 2 babies die every hour, we know that really these pregnancy-related deaths are going in the wrong direction. We talk about maternity care deserts, so counties where there is no provider, or labor and delivery or birth center to deliver at. We really go into the 22 report and then the 23 report, which again was released in August. We really dive into miles to drive to receive care, to deliver, but also where reproductive care, how far they have to drive for that as well. And then we get into a ton of the disparities in the vulnerability index. And then we dive into a little bit about governmental or changes within each state. So I'll leave it at that. When we get into how health disparities with race, this is when I say if we could solve this problem for Black moms and brown moms in this country, we can solve for all moms. And specifically, I cringe at the second statistic here about Black babies are 2 times more likely to die by their first birthday compared to their white counterparts. When you start looking at things like preterm birth, or you look at inadequate prenatal care, comorbidities, and then you add in maternity care deserts, it actually goes exponential, which starts to get quite frightening. And so this is the data that I hang, like, why we need to be focused here, because this is really where we need to be making the difference. This is who is the most affected. And we do talk a lot about inadequate prenatal care as well, and that leans into that access issue. And we'll get into that a little bit more too. So I threw this slide in. It's actually not one that we often use, but we just started using this one because maternal mortality rates really are going in the wrong direction. The CDC just put out their infant mortality data. It was, I think 2 weeks ago or 3 weeks ago at this point, and we put out our prematurity birth report card right around the same time. And I always think of the report card as just like you would as your child gets a report card. It kind of gives you the state of maternal and infant health in this country. And it does give you a window into the healthcare of the country overall, because our preterm birth rate, right, we're failing. So kind of embarrassing, to be honest. And then when you start looking at it state by state, there is no state that got an A. I think the highest is a B, and you're looking at like New Hampshire and California. Why New Hampshire? Not sure yet. But looking at the swath of red across the Southeast is absolutely glaring. So we'll get into even more of that. So this is really our access to care and the preterm birth report card. So you can see your states, and I don't know if you guys can see my, where you all land. There's a lot of opportunity. And we know that this is somewhere where we can focus when it comes to preterm birth. We have not seen a ton of therapeutics, right? Change here. We know this is a big access to care problem. Again, layering in our maternity care desert, when you overlap them, you'll see that data really progressively showing. So then we lean into moms. We know that, this is when you start to look at, again, more CDC data that is all headed in the wrong direction, and that our maternal mortality report begins to highlight that we really are, a place that this is where the major focus should be. And I think we are just starting. I find it always embarrassing when I talk to a new reporter who says, I didn't know about this. So we need to continue to amplify this. I think everybody on this call probably knows the data, but feel like this is where I just continue to push, because I want to make sure that we are speaking to it. So we have the highest maternal death rate in the world. Every 12 hours, a woman dies from pregnant related causes. And a pregnancy-related death is defined as the death of a woman during pregnancy or within 1 year of the end of pregnancy. From a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiological effects of pregnancy. And I like to qualify that just so that people know what we're statistically really talking about. And this mortality rate, right, it's doubled from 10.3 per 1,000 live births in 1991 to 23.8 in 2014. Over 700 women in the year die of complications related to pregnancy each year in the US, and 2/3 of these are preventable. And that number is where I start to think where we can have the biggest effect is those preventable deaths. Maternity care deserts are almost 150,000 babies are born in women living in maternity care deserts where there is high poverty rates, lower household incomes in the counties with access to care. And among women living in maternity care deserts, 1 in 5 lives in a large metropolitan area or urban setting. So we have a lot of people always say to me, maternity care deserts are only in rural areas. Actually, 60% are rural and 40% are in inner cities. We actually have one. I'm looking across the Potomac right now here in Washington, D.C., and we have a mobile unit in one of our maternity care deserts right here with a partnership with the University of Maryland, seeing patients. And you might say, well, why don't, and this is something that a young person asked me, why don't they just take an Uber? Doesn't work like that, right? It's it's several buses to be able to get over to that care with 3 or 4 children in tow, or even one other, or none. It's still not the solution. So I just thought I'd throw in a little bit of history. I always joke I am a history major. That's what I majored in college. I love the history of things. And one of the things that really struck me about the March of Dimes is its 85-year history. If you don't know, we started with FDR, one of our greatest presidents, who had polio. And so he said, this is a crisis. Send in even a dime to the White House to fund the research to solve for this health problem. And that started in 1938. And that actually helped, right? That huge campaign, probably the first crowdsourcing funding now that I think about it, and really funded, which by the way, a dime today is $1.85. So imagine if we got all Americans to do that. But the funding of the polio research came through the March of Dimes and through our research. And then that dissemination, in the 60s, and then realized that we then pivoted towards birth defects, or really continued, I guess, in birth defects, disabilities, shifted towards preterm birth, and then in the turn of the century, focused more, and really a little bit before that, because I think the understanding was really, which we all know, is that outcomes for babies start with moms. And so with it, whether it was our national service partners and doing Stork's Nest, which is something that we have done in communities across this country. It started in Atlanta in 1971, and helping women obtain prenatal care, attending educational classes, getting them diapers, food, and now transportation and other educational materials for it has been a significant community outreach and partnership with with the Zeta sorority that has been really influential. And watching that shift towards maternal care is where and how we've done it. We're one of the few nonprofits that actually solve for a problem, which is great. We continue to do prematurity research, and I'll get into that a little bit. We continue to do a lot of advocacy, a lot of education, and continue our programming. But this is kind of a neat history there. I think I had Virginia Apgar, who went to Johns Hopkins after being turned down as a faculty member at Columbia. I went to Hopkins as an undergrad, and that's where I went back to get my MBA. So I always give Virginia a big plug. I also think she actually died in New Jersey, which is where I am now living. One of the things about Virginia and Apgar in this job is I've always sort of joked when I was in the operating room that one day maybe I'd have, an instrument named after me, or something, a maneuver, all those kind of things. And I would tell you, I never thought that I would be in this position, but really feel that this is the time for a provider to be, at the March of Dimes, and hoping that, as this timeline elongates, that somewhere in there I will be, but no pressure for me or anything. So, listen, I want to focus in a little bit about what we do and what we are trying to do in our strategic focus. We really want to end preventable maternal health, maternal morbidity and mortality. Same thing for preterm birth and infant death. We know we focus in on preterm birth and birth defects. Those are really the number 1 and 2 causes of infant death. And we use everything we do. We use our health equity gap, and we actually have a framework we use, which I share a little bit with you, into every project that we do. So I'm assuming everyone on this call knows, so I feel like possibly a little silly, but want to highlight that we know maternal morbidity and mortality, that the cardiovascular, maternal cardiovascular health is one of the number 1, as well as maternal mental health. We know that it's preterm birth and birth defects, as I highlighted. As I go through the health equity, these are sort of the things that we've come up with, a framework that we use, and our maternal baby and action network uses across all of our programming, to think about that, making sure that we're focusing in on each of these. And that's racism and unequal treatment, our access to high quality healthcare, environmental justice, lifelong economic security, safe and connected communities. All right, so, one of the things that my colleague said to me when I first started, actually, it was a physician colleague who I went to MBA school with, said, well, what does the March of Dimes actually do? And I said, oh, we do a ton of education. And so, well, why do I see you on the Hill? Well, we do a ton of advocacy, and then we do research. And I kind of clump in research and data. And that is really the 3 things that at our core of what we do, and what our donations fund and event, come together. We put programs together and we become the convener. So I mentioned the mobile unit. We have mobile units across the United States doing what I would consider pop-up maternal and infant care. We're in like Appalachia. We're actually in New York City. We're here in Maryland. We've one launching in Arizona. Houston, Texas is, I think, our next one. And those are all places that we are not providers. We are the convener, though. So we'll have a corporate partner who will want to sponsor a bus, and we will coordinate to get that together and do the evaluation of the program, but get the right clinical healthcare partner together to actually launch that program. So that's how I think of the March of Dimes, as a convener. So what I replied back to the person that I had gone to school with, my colleague, he said, so what swim lane do you go down? And I had to think about it a little bit. And my response was, we're actually not in one of the lanes. We're actually the swimming pool. We like to bring everybody together. We hope they swim down a lane and that we are successful together as one, but we really think of ourselves as the swimming pool. I like the analogy. One day I'll put a pool up on a slide. I haven't gotten there yet. So when I think about some of the work that we do, we are doing a ton in prematurity research. We've got, not only do we give individual research awards, we actually have 7 sites across the country. If they're not in Cincinnati, they're in San Francisco. They are, again, across the whole country. We even have one in England, actually, that's doing some amazing stuff. And again, this is trying and really making a community together. I just sat through a half a day listening to each of them present to each other, and so that they share data. And I love the collaboration that's happening. I love seeing that we are trying to get from bench right to bedside, but also to say actually that we have better data over here versus there is more collaborative than saying that kind of, right, it's not a race. It's about how do we come together and maybe we share data to actually move solutions forward. So I get excited about that. We have an inaugural health equity center at University of Pennsylvania in Philadelphia with the chairman there. Her name is Elizabeth Howell, and doing some really fantastic work there with looking at support within NICUs, as well as some doula work. And then, as you know, we put out the Maternity Care Desert Report Card and our annual report card. Programs, we've been doing group prenatal care, called what I call it SPC, but it's supportive pregnancy care. Really trying to, and again, through COVID, had to do like the telemedicine and have shifted back to it live and in person. We do a lot of training. We're not providers, but we help you set up that program. We do NICU family support. So we are in 79, not quite 80. We're hoping for 80 in the beginning of 24 NICUs across the country. And those NICUs actually have boots on the ground March of Dimes employees who are helping with supportive programs. If it's not education, it's really making sure we're connected care. And we have a fantastic pilot we're doing right now in mental health, where we actually screen moms and support people, dads, family members for anxiety and depression. You can imagine, right, at that NICU delivery can sometimes be incredibly traumatic, and really supporting our moms right where they are. And we've had a great pilot of screening moms and having a high response rate. What's even scarier is that I want to harm myself question in the Edinburgh is scoring through the roof. And so especially with support people, which you can imagine, as I see it, as the person who watched their significant other go through a big trauma. And so we've been doing a pilot program in 3 of our NICUs and are excited to expand that throughout the country. So I mentioned the mobile units. I won't delay there. Advocacy, we just passed the Preemie Act. So I testified on the Hill, which I'm not going to lie, was a little scarier than doing a C-section in the next room. So a little more comfortable doing that than I was going up to the Hill, but testified for the passing of the Preemie Act, which just passed the House. I guess that was today. That was Tuesday. So, and it was live on C-SPAN, which was very exciting. So that really, the Preemie Act really supports more research into prematurity and the causes behind it. It also looking at therapeutics, but it also does education and support for families. That was a reauthorization. So, and if you look at pictures of me testifying, you can see a text message on my Apple Watch from my mother that says, "You're live on TV." I was like, "Oh, great, Mom, thanks." But so that was slightly embarrassing. However, my 82-year-old mom, huge supporter of the March of Dimes as her neighborhood and family really, she grew up, with polio in her neighborhood. So, I think her proud moment was seeing me on C-SPAN. I was more embarrassed that I was, making sure I didn't fumble through it, but it is what we do, and we pass things, which is fantastic. And it's also at the federal level, obviously, but it's at the state by state. We know there are differences state by state, whether it is, extending Medicaid in the postpartum extending postpartum care for Medicaid, whether it is, telemedicine, expanding that. Certain states aren't covering it, which to me is kind of crazy. And so these are the things that we continue to work on. We did pass also the protection for pregnant workers as well. So, and the paid leave. These are big accomplishments that our government affairs team has accomplished, which is really exciting. And then fundamentally, we do a ton of education. So if you go to our website, you need information on preeclampsia, you need information on diabetes, we have it. And we try and really do a ton of that. And there's a big refocus going into 24. We have programs like It Starts with Moms, which is everything from webinars, or Birth Defects Awareness Month is coming up in January. So we have tons of information that is accessible to both providers and patients, or around here, they call them consumers. I like to still call them patients. And we have implicit bias training for providers. We do a ton within NICU family support, and that is a NICU journey versus, right, having a full-term infant with a birth defect. We know those are different trajectories and courses, still a roller coaster ride. So we have provided a ton of information there, and it can be on breastfeeding, the rest of, it's numerous. But we really love the partnerships that we are collaborating in. This year, we are doing a ton of neat stuff. So we have, and I'm going to get into that next, and I won't talk forever so people can actually ask me questions if they want. But our perinatal data center, which we call it our PDC, we continue with our report card and continue to churn out data. Our partnership this year was with Elevance for our maternity care desert report. And by the way, if you go onto our website, and this is just me being nitpicky, the top one is 22, so make sure you go to the next one, which is 23. I'm still trying to get IT to fix that. I always think the top, right? But I was turned down on that a couple of times, but just make sure you know that. So you want the 23 report. But it is free, download it, pass it along. And then our report card really gives us state by state where we're at. And I think specifically I tried to get North Dakota and South Dakota in here so you all could see your own states, where we dive in, and again, across the whole country as well, but we get into all of the factors that cause this. And whether it's chronic conditions, smoking, right, prior preterm birth, we know the causes, but are we doing the treatment? So the US received a D+, kind of embarrassing, right, to tell you that, the country failed, but it just tells you we aren't putting the attention where we need to. So this is a decline, really, if you really look at it, it's a flat, right? We didn't really make any strides or any difference. And if you think about it from really 21 and 22, though, there's really no improvement whatsoever. And we know, though, over, actually, I think it was 14 states, even though we put 13 in here, the preterm birth worsened. We do know that there were 32 states where it pretty much improved, but again, oh, so slightly. And the question in my mind is always the why. And I always think what was going on in those states, and it's kind of interesting to see where COVID was during some of this reporting in a different, and I don't want to blame everything on COVID, but slightly different in what COVID regulations we had or support that we had in vaccination uptick. You start thinking about that. We know that impacted preterm birth. But also we know that prenatal care, lack of prenatal care increased. Our low C-section rate hasn't changed, which we still need to affect. And then our infant mortality was unchanged. So I'm going to move on to the report card. This is just what it looks like, so you all can see it. So we report on the preterm birth grade. We go across this looking at disparities by race. We go across kind of what all the factors and that's across the right side. This is the second page of the report. Again, all this is a dashboard for one to read. We love to show you the trend. I think when you look at any one data point, right, we want to see that. We talk about infant mortality at the same time. And then we dive into some of those major complications. And we usually tell a birth story at the end because I really find it really impactful. So this one, for instance, for Colorado and Alabama, we also go through a lot of the where we are with adoption of policies. And then again, the last is a birth story, usually from that state, if we could get it, because we did want to personalize it. And this, again, goes over our infant outcomes because that is super important and the related factors for both preterm birth and our infant mortality rates. All right. This is more reporting on how cool our report cards are. So I'm probably going to cruise through that because otherwise, right, we have really neat videos as well from different states that are on our for our maternity care desert report. This report goes down into the county level, so it's not just by state. We actually, on our preterm birth report card, go into some cities that are doing better than others, but here we dive into the county. We talk about the miles to drive, both for birthing as well as reproductive care, and then we dive into that vulnerability index as well. And overall, our report showing that we've had a decline in hospitals, right? We've had closing 4% across the entire country. And, we've got almost 150,000 babies born in maternity care deserts. And I mean, I could read off these numbers, but we kind of highlighted them. And we know that there's so much work to be done and that access to care, this is part of it. People ask me all the time, why is this happening? I'm probably speaking to the states that know the whys better than others. And again, sometimes hospitals are opening in places that are maternity care deserts. I actually think the U.S. News and World Report for the first time started reporting on where hospitals are in maternity care deserts, which is fantastic. Thinking about how some hospital systems are supporting it and others are not. We know it's a financial, right? Mostly, right? If it's not about lack of care because there, nursing shortages, provider shortages, and that we know that, maternity care has always been a loss leader within a hospital that hasn't been, that's been for some time, and needs to change. I can keep going on maternity care deserts, but I think you have most of this. I realize I'm like halfway through, so I'm going to cruise through. We did include, here we go. This is the one I wanted to get through. So we did include a lot of FQHC data in our report card, I think for the first time. And really looking at where they are, where they're being supported, and where women live compared to their FQHCs. So, and how many counties have none. So we wanted to highlight this in this particular report card as it's something that we felt was important to do. We also included family practitioners, for instance. So we feel like we're bettering our data every time. But this was one that specifically I wanted to make sure I highlighted for all of you. think you guys know this, and family physicians. Right, and births covered by Medicaid. Oh, here we go. So this again, going into a state profile. And now I should let you know we're working on doula work this year. We've got a multi-year, several $million grant that we're working with CVS on doulas. And the way we're thinking about doulas is how to train, retain, and integrate them into our system. And so this year has been all about planning for that grant, and then launching in 2024. So we were excited to be able to awarded this grant earlier in the year. The work began with actually the planning, which was like for the first time I think I've ever seen a grant say like you're not launching, you're actually going to do 4 months of planning before we actually launch, and in partnership be able to do this properly. So we're excited to see that work, and we continue to put this together, but our doula work together. So I went through each state. I mostly put this together so you guys would have it in your handout, so I don't want to keep dwelling on it. So here are some of the solutions when it comes focusing on our policies. I did talk about this a little bit earlier, and we are really excited about passing the Preemie Act. I can't believe we did it. And bipartisan. I think we only had 1 vote. I won't tell you who it was who didn't vote for it. You can probably guess, but I'll leave it alone. But to get something all the way through with almost 100%, right? So kind of on, somebody abstained, let's put it that way. And excited to see it, as we move through the Senate. But these are things that we are really focused our strategy through 24, and then really are, continue to work for supporting midwives and doulas, as we think that that is work that needs to be focused on as well. We know that are solutions to some of the maternity care deserts. They're not everything, but they're part of it, and that reimbursement needs to continue. Blanket change, I would, this is something we do in March. We have a fly-in on the federal. We all wear purple and run around, which is super cool to see this wave of purple hit the hill. I would absolutely encourage any of you who wants to get engaged, whether it's coming in on that day or whether it's you do it on your state level, which we tend to do the following week, across states across the country. So it's super cool. If you go to blanketchange.org, that's an opportunity to get involved with us as well. And then we are about to launch a low-dose aspirin campaign. Our low-dose aspirin campaign, if you don't know, is really about taking baby aspirin starting between 13 and 16 weeks. And what we're trying to do is hit patients who, and again, using the standards of care from the American College of OBGYN, SMFM, the U.S. Preventative Task Force, that we know we can affect pregnancies, preeclamptic pregnancies. And we know that we could extend gestational age and have better outcomes. We see this as just as exciting as our Born Too Soon campaign, which was our don't deliver before 39 weeks. And so we're really getting excited to pull together partnerships to be able to launch this. So this is a little sneak peek to it. And this is sort of statistically where we think we can move this. When I start thinking about the history of the March of Dimes and how we've gone into communities with folic acid, I can think about North Carolina, for instance, and folic acid, not only getting into our wheat, but actually handing out prenatal vitamins. When you look at the statistic of spina bifida and neural tube defects in North Carolina, compared to any other state where we actually hand out prenatal vitamins, we've had the biggest effect over 10 years and actually decreasing, by 30%, where it's been 15 to 20 in other states. And it's because of really getting involved in campaigns like our folic acid campaign. I think low-dose aspirin has the same thing as the impact we could possibly have. All right. I'm not going to get into this because I'm hoping everybody else knows this. This is our doula work, which I skipped. And then our mobile units, which I already highlighted. So I think I'm getting to the end so that people can actually ask me things. Yeah. And this is my contact information. So my email address, you're welcome to email me and certainly get involved. I'd love people to go to our website. It's not just about donations, which we're happy to take, especially as we end the year, but really about some of our programming that we're doing, and getting all of you involved with March of Dimes would be probably my biggest ask in some way. Whether it's advocating for us, contributing to our education, even proliferating our educational material, or doing, really helping us with some of our data and getting it out there. Those are all things that I could see as partnerships with all of you. So with that, I'm sure I babbled for a good almost 40 minutes. So Jen, I can take questions or they can put them in the chat, or we can go from there.
Yes, absolutely. We do have lots and lots of time left. So I am going to leave it open for any questions. Feel free to just come off mute and ask if you like. Now, while you are kind of thinking, I had a couple questions for you while folks were pulling their thoughts together. The low-dose aspirin campaign, you said that was starting soon. When are you guys kicking that off, and what kind of, are there going to be toolkits, or what do you anticipate that's
So we already actually have toolkits. We piloted in California. We know California is not Tennessee and is not, let me see, New Hampshire, right? So we started looking at it with implementation science and really looking at where do we need to get to be able to. This is not as simple as handing out prenatal vitamins. This is not as simple, well, not that it was simple, of really getting out the word on 39 weeks, right? And the Born Too Soon campaign. This is a little more complicated because you need pharmacists, you need, right? I need all the providers. I need patients to be asking about it. And really those that are eligible, which if you start to look at the criteria, if you're over 35, right? That's one of the, I mean, it's amazing what it looks like. So we do have toolkits actually already built. We are looking at not only just a massive amount of education. We are hoping to launch with SMFM in February at their event, but it may be pushed a little further. It's not because SMFM actually wants to be our partner. We're just want to make sure as we launch that that cascade of events can happen afterwards. So what that would include is getting webinars and getting information and educational material ready to go as fast as possible. And so there's a few things that have to be into play, but yes. And we're also working on pharmacists because you can imagine, right? Who, when you say don't take aspirin, because that's actually what, right, versus low dose aspirin, and understanding exactly what it is. Interesting what ACOG has said is they're they are not ready to say hand it out all the time. So it's but SMFM is much more of a willing partner with us. So we're excited to be launching with them.
And will you spell out that acronym for me?
Oh, Society of MFM, Maternal Fetal Medicine. My bad.
Okay.
Yeah, versus ACOG. Yeah, the American College of OB/GYN. So, and they are, so the way I always think about, right, maternal fetal medicine is sort of that maybe one more layer above ACOG, or to this, I shouldn't say that because I'm a fellow of ACOG, but to the side maybe. And so they are really excited to partner launching this. And as I said, the small pilot we've done out in actually our prematurity research center in California, developing all of our toolkits, which are just about finished. And then we're just thinking about how our dissemination plan will happen. And that's where I would say there was a huge partnership that we could do together to get the information out there. We're hoping that we get to patients who will then say, right, we want, should I be on aspirin? And again, low dose aspirin, but providers to really make sure it's, tools within their EMR system and the rest of it, and data that we can end up collecting, which starts to get really exciting about making difference. What else? Mobile units is another pretty cool project that we have. Only 2% of all mobile units are in maternity care. So when you think about it, when you think about mammography or the blood banking, whether it's Red Cross or others, that they readily use mobile units. We have been using mobile units actually for some time, and now have gotten into a model where we partner with a clinical partner, and after either 3 or 5 years, hand the bus over. So we started sort of like that initial pilot, get it off the ground. I do think of it as a pop-up. It's been kind of interesting to see happen in like Ohio, in the middle of Appalachia, where people are getting served not just maternity care, they're getting screened for STDs, they're getting plugged into the system in a lot of ways. And we've done pop-ups for food, we've done pop-ups for other ways of getting transportation, and then getting into whether we are bringing social workers or community workers to be able to get to patients where they need to. So it is a great way. People love to put their logos across these buses. To me, I think it's fascinating to be able to bring the provider to the patient, which, is what we used to do, right? Of having a provider actually take their doctor bag and go to their house. So this is kind of, I think, reminiscent of one step closer to that, but the idea of a pop-up kind of makes sense in these different communities to be able to help serve them best.
And if I can ask a follow-up question to that. So a lot of our health centers do have mobile units, but I think it could potentially be interesting for some of the others as, possibly a low risk solution to trying out the mobile model. How do you all select the organizations that you guys work with? Or is there anything that our health centers can do to get on that list?
Yeah. So so first of all, that's an easy, you can email me, B, you could on our website, go to our mobile units and you can actually we've got a whole team that does this. And so we have done it where we've partnered where the bus is already doing primary care somewhere. How do they either have to fit out the bus? How can we partner to be able to get maybe the same providers, but help with how we would structure it just to get it off the ground? We've done that. As well as we've been approached by payers who are super interested in being, purchasing the bus and getting that out there, and then they say to us, we have a whole criteria of picking our clinical partner. And so that's where I could see in this setting, like we could absolutely do that. That would be fantastic, right? And then we do a lot of the data collection to be able, with our perinatal data center, to be able to look at outcomes data. The difference between someone who didn't get care versus gets care. We know there's a 3 to 4 times more likely rate of a morbidity or mortality. Can we, figure out was there not preterm birth because of a mobile unit? And we've been doing that data and deep dive within our units just, I would say within the last year to really make sure that we're getting outcomes data for patients that are really some of the most vulnerable. So the way to do that is either email or go right onto our website and you should be able to go to our mobile unit. And I would forward you on, don't think you're going to talk, I'll get you forwarded to our mobile units. We have a huge team. I actually just hired a new coordinator there. And if I didn't tell you, we're in Ohio, in Appalachia, as well as around Columbus. We have a possible third bus going somewhere near Cleveland. You can probably think who that clinical partner might be. We're hoping to sign that by the end of the month. We've got one that just launched in New York with New York Presbyterian, and that's a super exciting. We've got Philips partnering to bring in all the ultrasound machines. So we end up with really neat partnerships. We've got the one that's in Maryland, Arizona. I said Tucson, did I not? Arizona and Tucson. And then we've got Houston, which is really exciting, and possibly one in the South. So, and the goal is for us not to own, buses across the country. The hope is that we start this as a pilot and hand it off as soon as it's ready and, and stable, and also that we can make sure that access and that health quality is there, because we would continue to support.
Excellent. Well, I don't want to take all the questions, so I do want to make sure that our participants, I see Dr. Penny, you had popped on video for a second. If you have a question, please do interrupt me.
Hi, I just had a question a little bit about what the supportive pregnancy care program, the group prenatal care, like what are the resources that you offer to folks to sort of get that up and running or expanded or whatever?
Yeah, so we have a couple models for that. We can train, come on site and do a full training. We kind of do a train the trainer. So we're not providers. Like I keep after reading that because I tend to speak as if we are. But we come in and we'll actually set you up with all the education material, get you trained on site on how to implement and all the resources that you need so that we can hand it off for you to implement and then collect data on to get to those outcomes as we talked about. But we used to do it we had a couple of variations where it was remote training, which just doesn't go well. But we actually come on site and do all of that for you. Yeah. So, and that's
do you find people, so like 20 years ago, I had some startup grant stuff and we implemented centering. Yep. And then, which was great. And then, but it's not sustainable. The centering model is not, the model of care is fine. The centering cost to be affiliated with is not sustainable for FQHCs. But then with March of Dimes, they had another thing called Becoming a Mom, which they wanted without in the community. And then we put it into the clinic. We got a little bit of money for that. That's been great because there hasn't been a problem with like branding or anything like that. One of my questions, though, is that there's like nowhere in the country that really offers training, because over the years we've had a lot of staff come and go. I have several clinic sites that would love to get this up and running. But then, so yes, like bringing someone in, but also the sustainability piece of it. Like if there's park stuff with the March of Dimes, whatever you call it, the supporting pregnancy care program, like that you have to continue to have a license or something.
Yeah, so what we continue to do is make sure that you're maintaining, you know, the highlights to, well, I'll just call it highlights or requirements of the program, and then come back around with trying to collect the data with you for outcomes data. Because I think it's important, if you have a program, you can most likely get funding yourself, or or partnership, if we continue to have bettering those outcomes. So we've seen that fall off the wayside, because a lot of times we have seen that data hasn't. And then continue to support by coming back around to make sure, and back around is probably the wrong way, but ongoing support to make sure those programs are off and running. And we've got somebody, we have a executive leader who is supportive of running that particular program. I can connect you to her if you're of interest to talk through it.
That's great, thanks. I'm always just interested. I know, so I'm in Denver, and there's 4 systems of FQHCs. Everybody did centering at some point, and nobody ever does it
yeah, it's sort of fascinating. Yeah, centering's gone.
Well, there's a lot of money though involved with even reporting the data, right?
Yes,
like that is a huge burden, to tell you the truth.
Yes, and that's why we wanted to unburden that part. Yeah, which is not easy. Not everybody wants to, anyway, that's a side conversation we can have, but it can be very difficult to crack that nut. And we've been wanting to do that. We've done it in some places. Actually, there's a very large group in North Carolina that I could probably connect you with that has been doing it. And they've done a combination of SPC, supportive pregnancy care, and centering, and I just care that the data that I got, I don't care which system you use. It's a matter of, are we getting the successes out? Are we getting the outcomes?
I have a question. I don't even know what centering means.
It's group prenatal care is really how, so you are doing prenatal care where you're doing in a group setting with moms coming in and having that support. This is why we call it supportive pregnancy care, through every visit. And you're not individual appointments going into a room doing Dop tones and blood pressures and weights. This is all in a group format. They end up getting, patients are much more supportive and have a network and a framework as they move through their prenatal care.
Okay,
and
cool. Thank you.
It's been shown to decrease preterm birth. In the very beginning, my biggest issue with why I've been talking about the outcomes is I'm not sure that that data was robust enough. So we continue to follow that. But I'm glad you asked. Yeah, that was great. What else?
All right, I'm leaving a little quiet space so you all can jump in. And in the meantime, I would love to hear more about the doula work that you guys are doing and kind of some of the training. I know we've got several health centers that are starting to look into that work as well. So I'd love to know more about your plans for the doula work.
Yeah, so this just our planning group, I think, is finishing. I think it's actually they're wrapping up tomorrow. Started with the idea that we were doing doula work in about 17 different markets, so 17 different states that we were doing doula work, whether it was we had a partnership with one versus we're getting reimbursement in another. And so it became this, like, how do we coalesce this into a bigger program? And what are we doing well, let's say in Louisiana, with a partnership that we're not doing well in Tennessee? And so part of this is really taking the landscape of who is a doula, right? Here, actually, I can probably even share my screen. Why don't I do that? I have a great slide on it. Here we go. There we go. So we took the idea of really, there's been, and let me take a step back and say a lot of people have different definitions of a doula. Whether it's community health worker, whether it's a care navigator, doulas can absolutely be in that antepartum space, intrapartum, and postpartum. and some of them have, you know, tons of demand, others do not. The supply is obviously, we thought was really kind of off, and also not connecting the two. Like if you Google doulas, there isn't really, because, and a lot of this is because there isn't a standardization. And so what we are doing, especially in the beginning, is trying to figure out what is the demand, where is the educational opportunity, and can we look at the states that are reimbursing and seeing if we're seeing any different outcomes. So for instance, they reimburse in the state of New Jersey, you know, almost $1,000 for a doula, in the Medicaid. I mean, it's kind of fascinating, right? And then where you're in Tennessee, there's absolutely no reimbursement for doulas. Then you get to companies like Walmart, who are reimbursing about $500 for a doula for their employees. So we just were hearing and working with all of these different partners, as well as within different of our markets and spaces, to say, can we figure out the best in class of training? And really, can we figure out how to retain them, right? Because we know that that's going to be an issue. Can we also figure out how to support them as a profession, if you will, or at least economically, to figure out how to set up a business? And then one of our biggest hurdles, and I'm sure all of you have heard this too, is that integrating into the current healthcare system. So that means, how do you get into a hospital system and be accepted? And how do you also get into a hospital system and not be, you know, shunned? So that is sort of where ultimately this program is going. We have spent a lot in landscape analysis in the last sort of 3 months. And so I actually have a woman who is a doula, who's unfortunately is going out on medical leave for the next 4 weeks, but she has been running this project, and we pitched this to CVS, and they have a ton of information and education on doulas, but haven't been able to do this part. So they have been partnering with us for the next 3 years to do this work, and we're still in the very beginning of it, as we get through coalescing the doulas that we're particularly working with. I mean, I mentioned Tennessee is one of the markets, for instance. I can't remember if Denver's another, but I think it might be. Don't quote me on that though. And so that's what the doula project work looks like. And really also trying to dive into some of the, again, I'm all about making sure we have some of the data on all of this, and a lot on implementation science about if we are doing something different in one space versus another, are there other success stories that we could learn from? So I'll stop there. That probably didn't answer all your questions, Jen, but hoping that.
No, that's great. Are you expecting that landscape analysis is going to go into a report in the future so we can see all that data as well?
It's probably not going to be till probably the end of Q1, unfortunately, just because we literally have our lead person going on a medical leave. But yes, yeah, absolutely. Yep.
Great.
I can stop sharing, but.
No, I want to throw it back to the folks on the call. What else do you guys need? What other questions do you have for Dr. Cherot? Or what are some of the burning questions that you guys are kind of thinking on how you want to use some of this information? How are you guys starting to address maternity care deserts in your organizations?
It's a burden. Right?
It's okay, you know, we all love dogs.
I know, I have 2 of them at home. So
love dogs.
Yeah, that's great. No, I mean, listen, I think I get asked this question, like, how are we going to solve it? Right. And I don't know. I mean, listen, and mobile units aren't, right. That's not the end all. How are we going to do that? I think it's multiple layers, right, that we're all going to have to try and figure out. But realize it's getting worse, right? That this access problem is really getting worse. So we are going to have to think creatively, innovatively, to move this forward. I will tell you the one thing we have, which is super cool, which doesn't necessarily pertain to all of you, which I didn't talk about, which is our innovation fund. We actually have a philanthropic venture capital fund where I have donor money. We get to invest it in companies, and we just invested in something called Iron Health, Paramus, and something called radiant oximetry. So we closed 3 companies, and they get to splash that they're a March of Dimes investment. And I get to take other people's money to do cool, innovative technologies that I hope will move to, commercialization fast. The Iron Health is a wraparound service for moms. And actually, I know they just launched in West Texas, which is exciting to see. And what I'm talking about is everything from taking that hypertensive who you don't want to fall off the grid, right? Or that diabetic, or someone who needs mental health service or obesity, to be able to get a lot of these services that we tend not to be able to make sure get, and a lot of it's remote care. So we invested in that company. The second is a continuous blood pressure monitor called Paramus, and that is super cool. And that's in newborns, actually. So you avoid the umbilical line if possible. And then they just got FDA approved. They're actually in an NIH Radiant grant, which is a big accelerator, which we're exciting. They're the finalists for that. And then we're hoping that FDA approval will then be able to be used for moms. And then lastly, and then of course it's a matter of like, okay, we've got to look at outcomes for that and protocols, but we all know moms need blood pressure monitoring and that postpartum, a lot need that. And the last is something called radiant oximetry, which is a way to look at fetal heart rate tracings that are in, that not the third category, but the second category, and deciding, do they really need to move to delivery or can they wait? And so it's a novel new way of monitoring, or I should say slightly novel, as it's been used in the past, but intravaginally, this is really through abdominally. These are exciting inventions that we're hoping, we don't think that every single one's going to be a massive home run, but we are investing in technology to get to moms as soon as we can. And we love our innovation fund. I didn't talk about it because I'm not sure how much it intersects with all of you, but I just know, I think it's sassy. I think it's kind of, right? I mean, March of Dimes is 85 years old. We got to do something new and novel. And this is it. And, I just encourage all of you to get, involved in our walks, blanket change, our fundraisers and special events are in your communities. But know that we're trying to do kind of at all aspects of it. And I think the Innovation Fund is kind of one of our programs where we bring people together, and we've got a fantastic scientific community that weighs in. And these are people from, really very, very smart scientists across the country, as well as really neat venture capital who are giving their time and money. So I always say their time and treasure to us. And so it's and sharing their talent actually as well. So it's super cool to see where we're going, and hoping the direction we get to is getting these into moms and babies' hands sooner. So I'll stop there.
Harry, you had your
yeah. So this is part confessional, part I need cheerleading.
Sure.
But I work for Colorado Coalition for the Homeless, and we are partnered with Denver Health. And I'm a family medicine doc, but I've seen mostly adults for really the last 10 years. I used to do quite a lot of prenatal care, but I haven't done much in the past 8 years or so. But because of the huge influx that we had this year, we're trying to do our part by seeing a lot of prenatals. And so we're all, those of us who are at the coalition who are willing to do this, we're trying to get, bone up on our prenatal care again. We have moved our main clinic away from our so we have a main clinic, but that can be a little bit scary for people to come into. And so we have moved our prenatal clinic to our West End clinic, which is a little bit smaller. But I guess what the reason I wanted to participate in this is I kind of need to hear that even if we're not perfect, even if we don't have all this new technology, even if we're passing patients off at, I think it's, I want to say 27 weeks. I haven't gone there to that clinic yet. Are we still helping? Are we doing the right thing?
So remember, prenatal care is preventative care, right? So if you're getting them plugged into the system as a whole, right? And you're getting them comfortable with the idea, right? All of it. And they're not showing up to the hospital with absolutely nothing. You are making an impact. So I applaud you, because going back to doing something after, 8, 9 years would probably make me terrified. Right. And but labor hasn't changed much. I hate to say it, right? I mean, and it hasn't. So prenatal care and what we counsel in it overwhelmingly has changed in different ways, especially in the beginning. But absolutely, just remember, it's really fundamentally preventative care. Yeah, there's supposed to be 12 or 14 appointments, depending on, Medicaid or honestly, if you look at Europe, they don't do half as many appointments as we do, and their outcomes are better. So they're doing something different. And to me, it's getting plugged in the system and feeling like there's support, there's God, and they can ask those really, right? Those are sometimes some really tough questions. And so, and really getting them really, I hate to say, like, plugged in is really, hands off to you. Absolutely. So whatever we can, think about our educational material, it's all free. It's all on our website. Direct patients there, please. Cool. Well, unfortunately, I have to go. It was nice to meet all of you and appreciate the time. And if there's anything else that I can do, I did have at the end of everything, which was a heck of a lot of information I threw at all you guys, because I was like, there's so much I could tell you about. Please feel free to reach out, and I appreciate the time, Jen. Thanks for having me.
Excellent. Yeah. Thank you so much. Thank you to Dr. Cherot, and thank you to all of you guys for coming. I will send a follow-up email that'll have the evaluation, this information as well. I'll pull out some links to the reports directly. You can see the recordings from the last presentations as well. This presentation will be ready by next week for sure, so you guys can share with colleagues as well. Yeah. You go ahead and pop off. Excellent. And then if there's anything else that you all need, we really are starting a focus on maternal health. We're going to work a lot with the Region 8 Office of Intergovernmental External Affairs, but other things that you all need, I got lots of ideas just from the things that you guys have been sharing. Please don't hesitate to reach out to us so that we can kind of pull those trainings together for all of you guys. So I really appreciate you guys taking the time to join us today. And I hope everyone has a fantastic holiday season and gets a little rest after this year. So thanks so much, everyone.